everyone, and welcome to this panel discussion on pulmonary function test. So I would like to invite my panelists, Dr. Rashmi, Dr. Mrityunjay Pau, and Dr. Indranil. Okay, I'll just introduce my panelists to you. So Dr. Mrityunjay is Head of Pediatric Critical Care at Jorat in Assam. Dr. Rashmi is an additional professor in Division of Pediatric Pulmonology at AIIMS Bhubaneswar. And Dr. Indranil is an pediatrician, moved to adult respiratory medicine, but does a lot of pediatric pulmonology work, and he's head of respiratory medicine at JLM College, Kalyani. Okay. So what we'll try and do in the next 50 minutes is we'll show you a few cases, and we'll show you how it went on. And the major focus will be on lung function, right? So how does lung function help you in the clinical management of your cases? So let's start from a bit of basics, right? So Dr. Rashmi, can you just give us an overview that in pediatric age group, what are the usual lung function measurements that are available to us?
So thank you, Dr. Ankit. So whenever a child is coming to you, from the outset you cannot know actually what is happening to the child. So you have to take a very good history. You have to do a focused examination, and if the child is on any kind of treatment, you have to review the treatment response. So then, if you are not sure or the patient is not responding, you take the help of pulmonary function test. Okay? So initially you can keep three diagnostic possibilities. One is it may be obstructive disease. Asthma is an example, or it is a restrictive disease like ILD, or there may be a neuromuscular disease. Third one is there is a diffusion defect or problem in the gas exchange. So based on that, you have to decide which test you are going to do first. So spirometry is the most common test that is employed. So that will show you the flow volume curves and degree of airway obstruction. Okay? Suppose spirometry is normal and you are strongly suspecting asthma. So if the facility is available, you can employ this forced oscillation techniques or impulse oscillometry. So there are so many talks in this conference regarding these newer techniques. So that measures the reactance and the resistance of the airways. So in asthma, your spirometry sometimes may be normal, but the IOS or FOT values will be definitely abnormal. Suppose you are thinking of any restrictive disease, so spirometry may be abnormal. For the better quantification of the lung function, you can do advanced tests like body plethysmography or multiple breath techniques, gas dilution techniques, so that you can use. So they will measure the lung volumes. Please remember this residual volume, total lung capacity cannot be measured by the spirometry. Okay? Suppose you are suspecting there is a diffusion defect, particularly in conditions like interstitial lung disease. So what is diffusion defect? So we are breathing oxygen, but that oxygen is not reaching the blood. So in those cases, you can employ this test to detect any problem in the diffusion capacity, that is the DLCO.
Right. So thank you, Dr. Rashmi. And so you have different type of lung functions which are available to you, but things which are most important to us clinically still remains as spirometry and to some extent impulse oscillometry. So we'll try and focus on the most common lung function, which is spirometry. So let's start with the first case. This is a 7-year-old boy who has recurrent episodes of cough for the past 2 years. So a dry cough, early morning cough, while sleeping as well, and it worsens when the child is doing any physical activities, laughing or crying. Each episode lasts for around 2 to 3 weeks. The child remains well for a while and then has a recurrence. The child has never been nebulized but responds to oral salbutamol. It is more during change of a season, and on examination, the child looks otherwise well. So with this background, Dr. Indranil, what would you like to think about? How would you go about this case?
So if you see this case, this 7 years recurrent episode of cough, episodes of wheezing, and remaining well and responding to oral bronchodilators, seasonal changes, this all fits with the diagnosis of asthma. So clinically, it seems to be asthma. But again, when we stamp it a diagnosis of asthma, if you go by any guidelines, we should have a documentation of obstruction in the airways which is reversible. Reversible to bronchodilator, reversible to time, or reversible to oral steroids or that. So yes, clinically, asthma is a clinical diagnosis. This case is typically of that of asthma, but we have to document it and find out some other mimickers of asthma. So yes, we should do a chest X-ray, but the most important thing, 7 years child who can do a spirometry, a documentation by spirometry is very important, and see the bronchodilator reversibility, and then we can move forward. But when we see, again, the differentials are there. A patient who is child of 7 years, cough for 2 years, recurrent episodes, and episodes during coughing, laughing, crying, all are pointers of these hyperreactive airways and asthma. So yes, that should be my approach in that way.
Right. So this child has a chronic cough. We all agree with that. This child does not have any specific cough pointers which tells you about an underlying serious diagnosis. So these are the usual differential diagnoses we'll be working upon. Most likely a cough variant asthma, or simply an asthma where you're not able to document a wheeze, right? The child might have been wheezing previously, but you haven't seen the child. This child has come to you for the first time. Occasionally rhinosinusitis, bacterial bronchitis can be there. And as rightly said by Dr. Indranil, the basic investigations which most of us would like to do is one chest X-ray and a lung function test. Right, so we went ahead and did a lung function test. So sir, can you just help us to understand what these curves mean?
So is the point, okay. Okay. So yes, this is a flow volume loop. The flow volume loop tells us you can see that the concavity and the bronchodilator reversibility is the loop itself tells us that is the flow volume loops tells us that the concavity there and the bronchodilator reversibility is significant. This curve as such tells that the child is having an obstructive lung disease with very good bronchodilator reversibility. The loop, so the acceptability is also there, and you can see the absolute value. The FEV1 by FVC is 54 and the FEV1 of 49% with very good bronchodilator reversibility of 38% reversibility. So this is obstructive airway with good bronchodilator reversibility. So we can stamp this as obstructive lung disease with good bronchodilator reversibility, and with the typical history, we can diagnose this as a child of asthma.
Okay, so I think we all agree that clinically it was appearing like asthma, but still you are not able to make a proper diagnosis because you could not document a wheeze. In these situations, doing a lung function, a pre with a post bronchodilator lung function, a spirometry is something which is the best way out. So this child shows a reversible airflow obstruction and seems to have asthma, right? So we understand that asthma is something which is very common. So Dr. Mrityunjay, just briefly tell us that, how do you clinch a diagnosis of asthma in your day-to-day practice?
First of all, in this patient, we had a history which is suggestive of asthma, nighttime variability, response to oral beta-2 agonist. But just for our general guideline, we can narrow down the diagnosis by looking at the clinical features. There will be typically there will be presence of cough, a wheeze, and difficulty in breathing, chest tightness. And to be objective, the characteristic features will be that there will be usually multiple of these combinations: cough, wheezing, or nighttime chest tightness. And the symptoms will variable with time. It will vary with season. It will be variable in severity. It may be aggravated by exercise. So these are the characteristics clinically. And to be objective, to have a diagnosis of asthma as such, we have to do the lung functions. That is the spirometry. So what do we look in spirometry? We look for the expiratory airflow limitation and variability. So what do we do? The characteristic changes are that there is a decrease in the FEV by FBC percentage and whether the FEV may be low or normal. And what we see is look for is reversibility to bronchodilator, and if it's not there, then we can look for a positive exercise challenge test. And if everything is normal, we can do a 4-week test of inhaled corticosteroid and see the response to steroids.
So I think this is the standard GINA definition which talks about that you should have multiple of these. So just not cough, just not wheeze, just not shortness of breath, or just not tightness. You should have multiple of these symptoms, usually which are variable with seasonal variation and variation over time, and a positive lung function showing obstruction and reversibility, right? So that is the usual GINA definition. Now the problem is that in clinical practice, because asthma is so common, that you will often see manifestations of asthma which are partial, or so for example, you will have patients presenting with cough. You can have patient presenting just with shortness of breath or chest tightness. So if you have any variation from the usual pattern, then at that point of time, a lung function is absolutely mandatory to make a diagnosis. Now let's look at another case. So this is a 12-year-old child who has persistent asthma, is already on budesonide, 200 microgram twice a day, which we started 3 months back. And at this point of time, the child seems to be well controlled. So my question to my panelist is, this child looks well to me, right? We don't have any spirometry which was done, but the child was clinically looking like asthma. The child was started on inhaled corticosteroids, which was absolutely a correct way. Sometimes you may not be able to perform a spirometry. Treated well. So do you think at this point of time, should I send this child for a lung function? Do you think it is going to help in follow-up?
There are many studies that says that although we clinically classify the patient as control or mild asthma, we often see that after we do the spirometry, the patient has a more severe form. So even though the patient, we think that clinically it's under control, it would be a good time to get a spirometry done to objectively assess the control or state of the airway.
And Dr. Ankit, regarding if you do the spirometry in between when the symptoms are controlled and the spirometry is showing some obstruction, the lung function is low, lung volume is low, so that can predict that the child may develop some exacerbation in the future, and if the child is having continuously to have low lung function, even the symptoms are controlled, you have to rule out other diseases. So in that way, spirometry is going to help you. So if you get time, if there is feasibility, you better do a spirometry in between also.
Yeah, so I think that's absolutely correct. That's absolutely correct. So these kids do deserve a lung function because that will help you to assess control, right? So we'll just talk about it. So Dr. Mrityunjay, just briefly, would you comment on this spirometry?
In this spirometry, we can see that there is a significant change in the FEV1 by forced vital capacity by more than around 15%. The required criteria of change improvement after bronchodilation should be around 12 to 15%. So FEV by FBC change is more than around 15%. So this reflects reversible airflow.
So again, you have pre-bronchodilator curve, which is the blue one, which appears to be smaller in size and it is scooped. You have a post-bronchodilator curve, which is much better in size and shape. Now, in addition, if you look at the FEV1 by FVCs, they are low. The FEV1 values are low, and there is a significant bronchodilator reversibility. So again, an obstruction with reversibility. So again, demonstrating the fact that sometimes you will have children who are clinically well, or they're clinically well controlled as per the domain of current impairment. If you look at the past 4 weeks, they are well, but they still can have obstruction in the airways, and hence doing a spirometry in follow-up is a very good practice.
So in fact, Ankit, one thing, if you go by this spirometry, see the child is on budesonide and well controlled, but still showing an obstructive airway lung disease with a very good reversibility. So that means the child will land in exacerbation at any time after that.
Yes,
that means
that's
the child, though it is well controlled, that doesn't mean that the child will not go in exacerbation with this poor lung function test.
Absolutely,
so
you're
we
absolutely
should be skeptic and we should be escalating the medication in some form or the other so that or we are not assessing the child in the real way, that the control in our scale is, according to the parents may be control, but ideally it is not control.
Yes, so I totally agree with that. I think we'll just take up the questions. So just a minute. So what we are trying to say is that a poor lung function, despite a clinical well control, still means that it is a risk factor for future exacerbations. There is absolutely no doubt about it. There are groups of patients where you're going to underestimate your symptoms, especially in adolescents, especially in children who have had asthma for a long time. They sometimes, tend to tolerate their symptoms, and they don't realize that they are actually having exercise-induced symptoms, right? So,
And the child is only on budesonide. So 12 years
Yes.
child, with this spirometry, I'll add a lava in that case.
agreed. I totally agree with that. That this is a situation that if you have given budesonide for a fair period of time, you have looked at adherence, you have looked at compliance, you have looked at technique, and you have this spirometry, then adding a LABA in this situation is something which is definitely warranted, and that should be the way. So the treatment needs to be stepped up, even if you feel that the child is clinically well controlled. So, sir, you had some question or comment, sir?
So Gautamda, please.
I think this is a flow volume curve. To find out FEV1 by FVC, the volume time curve helps better.
Absolutely. But yes, again, the
Yeah.
system is generating it. In fact, the system generates this from the flow volume and the volume time
We
curve.
know the only thing unfortunately,
Absolutely.
most of the prescription, the printout only shows flow. The
Yeah.
only my request that ask to give the both printouts.
So usually, and that is what I was saying in the PFT workshop as well, that most machines, when you are trying to design the report, right? So it is our job to design the report, right? Either the FV loop or the VT graph, volume time graph, which tells you about the end of the test, should be there, and it is our responsibility that whatever equipment we are using, right, we should make sure that both of these graphs are there. So I totally agree with sir. A short comment from your side, sir. Absolutely.
We should increase, we should add an lava to this patient. Because
Yes.
this,
Yes.
because he is on higher dose of budesonide.
But you have to rule out the compliance, all those. Everything is fine, perfect. You have to think of.
Yes. So
Either
that's
the
absolutely
assessment
right.
of control is not correct, that is problem, or but the most probable thing is that the assessment of control is not done properly.
So we have data. So, and this is a very old study. And why am I showing you this old study is that this question is no longer being asked, right? So most of the pulmonologists will not be asking this question, that do you actually need to do a spirometry in follow-up? And that question, because it is not being asked, now it's not researched now. But this is good old data which shows that if you add lung function or you add spirometry to your clinical assessment, right, then you're going to upscore your asthma. So what it shows here is that if you use symptoms only, right, or symptoms with FEV1, okay, then the percentage of patients will move from mild persistent to moderate to severe persistent, because you are actually underestimating the asthma. So whenever you will add, that is not going to happen in all patients, but there's a definite group of patients whom you are actually underestimating the asthma. So doing a lung function and follow-up is something which is important, because if you don't do that, if you don't step up this child, then this child is again going to land up into exacerbations. Right. So Dr. Rashmi, time and again we are emphasizing that a lung function should be done, and again I'll come back to the basic question that just can you summarize why do you think a lung function should be done in asthma?
So this is very important because all of us, not all that wheezes are not asthma. You may get some bronchodilator response and it may not be asthma also. It may be something else. Okay? So that's why it is very important you do spirometry to document the reversibility. So airway reversibility documentation is the essential for diagnosis of asthma. Second point, there are some scenarios in which it is very helpful. For example, the symptoms are not clear. So we tell that the patient usually have nighttime symptoms. Any child who is coughing a lot at night, fine during the day, may be asthma. But please mind, we have seen children, they are coughing during the daytime, well at night, still have asthma. So unclear symptoms, chronic cough, no other pointers, child is fine, but he is coughing a lot. Examination is perfect. Spirometry is going to help you. Exercise-induced asthma. So you can do some treadmill kind of thing and document this obstruction. And in children with poorly controlled asthma, compliance is fine. Patient is not responding. Still you are getting wheeze on examination. So in that case also spirometry is going to help you. Okay, so these are the conditions where you have to do. Second, follow-up. Okay, suppose you have started treatment as we discussed. In between, spirometry is still abnormal. So you have to revise the treatment plan, whether the compliance is fine or not. Compliance is good, still lung function is poor. You have to escalate your therapy. Ideally, as per the GINA, the spirometry should be done before starting the controller therapy. But many children we get in that they are getting referred, they are on some kind of treatment. Okay, so if the child is on treatment, you have to do spirometry after 6 to 8 weeks. If somebody asks, what is the earliest time point you can do, it is 4 weeks. So never do before 4 weeks. Ideal time for doing spirometry is 6 to 8 weeks.
Okay, now, it appears to be quite good here when we talk about lung function, right? But practically, every one of us would understand that doing a lung function as children is fraught with problems. So just can you highlight for us what are the limitations you face doing spirometry in children?
So this is very, very important because there are certain factors that may affect the reproducibility, okay? If the child is small, so he may not do the spirometry. So spirometry is usually done in children who are more than 6 years because they can do it. But nowadays, even smaller children with good coaching, they can do it. Another thing, even bigger children, though we think that they can do it, we have seen that almost 10 to 20% adolescent, they are not able to do the spirometry properly. Okay, so that is one important point. Second is that spirometry may sometimes underestimate. Okay, so that means the child is having severe asthma, but the spirometry may be normal, or you have classified that the child is having moderate asthma. The spirometry may show some severity in the abnormality. So there may be the discordant in the symptoms. Another point, suppose you are doing the FeNO, that is the fractional excession of nitric oxide. So that is another modality that will tell you the eosinophilic airway inflammation. So sometimes the spirometry may not correlate with that. So you will find difficulty in deciding the type of treatment, okay? And the exercise spirometry, sometimes you have to employ, particularly if the child is supposed to have this exercise-induced asthma. So these are some limitations. And please remember, if you are strongly suspecting asthma, spirometry is normal, better you can do this IOS or FOT.
Ankit, another thing which I should tell that in most of the children, because they do not exhale it for the next 3 seconds or so, we get a restrictive pattern. So this restrictive pattern should be taken with a pinch of salt. So they should be trained, see whether they have adequate flow, and then it should be interpreted.
So this is very, very important. Ideally, the Gautam sir was telling, the flow time come is very, very important. Okay, in adults, the time for exhalation should be at least 6 seconds, and children it is 3 seconds. So anything below that, suppose the child has exhaled for 2 seconds, please do not interpret that spirometry, you will land up in problem. So minimum time for children is 3 seconds. If the child can exhale for 6 seconds, that is well and good.
So restrictive in pediatric age group in spirometry is something which we get, and it should be again interpreted cautiously.
So absolutely agreed. So if you have a forced expiratory time, for which you need a volume with time graph. Now if the time for which the child has exhaled, if that is less, then what you underestimate is the FVC. You can still interpret the FEV once, but the FVC is underestimated. And when you underestimate your FVCs, then your FEV1 by FVCs are erroneously high, and hence you can actually miss an asthma. Okay, so Dr. Rashmi, how would you, we know this is a very robust investigation. But also know that there are limitations. So can you help us, everyone, to understand that how do you actually overcome?
Suppose a child is not studying actually, so what you do? You provide some kind of coaching. So same you have to do for the spirometry. So you have to coach the child. Suppose the child has not done a particular setting. You fixed another date, then do. Okay? So then what happens? Maximum time we refer children for spirometry to adult pulmonologists. So their technicians are not children friendly. So ideally, if the facility is available for spirometry, you have to send to a pediatric pulmonologist or a pediatrician who has a special interest and is expert in spirometry. And there are some spirometry devices now it is coming up with some incentives, okay? So in that computer screen, for example, so there may be candles. So you have to tell the child that you blow forcefully so that you can blow off all the candles. Okay, so in that way he will get kind of the motives and to try forcefully exhale. Okay, another point, you can ask the parents to do first and then ask the child to do. So he will get the motivation because sometimes the children, they will fear of the instruments. Okay, something might happen. So if the parent is doing so, they will get motivated to do it. Another point, you can give some reward. Okay, if you do this in this way, you will get some reward. So these are the incentives you can employ. Suppose.
Yes, sir, a short comment because I'm just running out of time.
Sorry, only one. For the spirometry, the FEV1, FVC are effort dependent. But there are a small part of it, maximum mid expiratory flow rate, which is not effort dependent. Can I use that? And this is not recommended in GINA.
No, sir, that is a problem because studies have shown that it may not be useful. So though you are correct that it will not be affected, but again the reproducible is poor and even in adults also, studies have shown that they are unreliable actually.
Unless the but exhalation time is adequate, it will not, an effort is there. Another thing which we do practically is, I bring up the child and show him, see another child is doing, how he is doing, and see he has not blown that correctly, you have to do it correctly. When he sees some other child doing that, the child does it in the correct way.
Yeah.
So again, if the exhalation time is less and the rest of the thing has been done properly, it has been a good start, the back extrapolated volume is fine and everything else is okay, then FEV1 still can be interpreted. The rest of the values cannot be used. Right, so.
Another thing, Dr. Ankit, suppose the GINA recommends that you have to do spirometry at the beginning before starting therapy, but it may not be available. You may be working the remote area. Please do not wait for that. You can start therapy and review the response also at 4 to 6 weeks. If it is actual asthma, the child will beautifully respond, okay?
Yeah, so.
But if it is available, you can do. And as I told, if spirometry is normal, still you suspect asthma, better go for this F40 or IVS. You can do FeNO also, just to know whether it is eosinophilic or neutrophilic inflammation. So if FeNO is elevated, the patient will respond in a better way to ICS. If it is not elevated, the response to ICS may be poor. So it may be a neutrophilic kind of thing or something else.
So we totally agree with
iOS, practically these are all changing. Now we can pick up more obstruction and reversibility is also very good there. So iOS or FOT is a tool. If we have that advantage, it will pick up more. Even in adults. Adults, we are doing that.
Yeah, so what we are again trying to say is that doing a spirometry is a good practice. In case it is a typical asthma and if you don't have access to spirometry, putting the child on treatment is absolutely fine, but you should be able to monitor that treatment, look at improvement in symptoms and a good follow-up. There are situations where you actually cannot make a diagnosis. In those situations, a lung function is something which is mandatory. Okay, so I'll just rush up a bit because we have 3 cases to show you and then we'll spend some 10 minutes on iOS. So in the next 8 to 10 minutes, we'll show you a few interesting cases. So just to summarize, this child is 7 years, has chronic cough for the last 4 months, It's more in the night, it is bad in the winters, so again seasonal variation is there. There's some nasal block and recurrent throat clearing which is there. So there is some history of aeroallergen sensitization which is there. There is no family history of asthma, and this child is still on treatment with salmeterol and fluticasone, right? Now this child obviously has presented to you because this child is not improving, right? So Dr. Indranil, what would you do ahead?
So yes, you see that differentials of asthma, all that wheeze is not asthma. In fact, though the child is presenting with cough and recurrent wheeze, but the dry cough, patient is on medication ICS LAVA, but the child is not practically recovering. And from the history, there is presence of nasal blockage, rhinorrhea. So one is it may be asthma with comorbidity allergic rhinitis. The second, maybe we are not dealing with asthma, the other differentials of asthma, GERD, post-nasal drip, or say, allergic rhinosinusitis, or it may be because of drugs, maybe there which should be taken. So again, it has been elaborated here, chronic cough with no specific cough pointers, recurrent upper respiratory, post-viral cough is another important, but it is usually not for 4 months. So if it is between 2 and 6 weeks, 2 and 6 weeks, okay, we can think it is a post-viral cough. Asthma and chronic rhinosinusitis, that is due to allergic rhinitis, are the two important causes, and in this case, there is a pointer because the stuffy nose and rhinorrhea is one of them. Habit cough, pertussis, GERD, and this protracted bacterial bronchitis are the differentials. So one very important thing which we think of the chest X-ray, which we do normally, and if we see a normal chest X-ray with this chronic cough lasting more than 6 weeks, think of asthma, think of post-nasal drip, think of GERD, habit cough, or some drug-induced, not in children but in adults also. So these are some things, and spirometry or an impulse oscillometry, and if required an allergy skin prick test may be helpful.
So this child, we went ahead, did a spirometry. The spirometry is normal. You have normal pre and the post broncholateral graphs. The lung function is also normal.
So what Gautam was telling is very important. Here we require the volume time curve.
Yeah, absolutely.
Because I don't know, it looks like very small restrictive. If the volume time curve was there, or at least the exhalation time was given here, we could have got the exhalation time was more than 3 seconds or not.
Yeah. So we have a forced expiratory time here at the end. So it's around 5 seconds and 4.65 seconds.
It is written there, forced exhalation time. It is written
So,
there.
so this spirometry was normal. And when we went ahead, evaluated this child, so this child had a very bad pansinusitis which was there. So we are not trying to say that you get CTs for all patients, but this is a patient where it was a diagnostic dilemma, was not getting better, and we required a CT, so only in some situations, right? So they're mimickers of asthma, where a lung function can be quite helpful. Okay, so another child, similar age, but has a slightly wet cough for around 8 to 10 months. You've seen the character remains same, persists, more on exertion, more in winters. And sometimes the wet cough is not very clear when the child presents in the OPD. Sometimes it is difficult to pick up. Now, this child is a known recurrent wheezer, wheezes with viral infection, has 4 or 5 episodes in a year, responds to nebulization, right? But now this child is not getting better. Okay. So on examination, it seems to be a wet cough. The ENT examination seems to be fine. There is no clubbing. The systemic examination looks okay, except for a bilateral wheeze. Now, this child is already on this treatment, budesonide, formoterol. You have looked at adherence, compliance, comorbids, and everything is sorted. So my question to Dr. Mrityunjay is that, this seems to be falling into a domain where you feel that it is difficult to treat asthma. Okay, so just can you help us to understand what are the types? So in just 1 to 2 minutes.
In this patient which has a long history of cough, and the cough is wet, but also there's wheeze. So we have to determine whether the patient is a patient of uncontrolled asthma, whether the technique that has been used is okay, whether if the patient is compliant. So it could be simply a uncontrolled asthma because of a faulty technique or lack of compliance. So a spectrum that we are looking for are like, it could be a difficult to treat asthma, it could be a case of pacemaker who is therapy resistant, but this patient is in a lower dose till now. And some conditions, like Dr. Indrajit said, asthma plus. There is asthma with comorbidities like allergic rhinitis, obesity, GER. This is termed as asthma plus. And on the other side is that this may not be a patient of asthma at all. So we have to think of all these probabilities in this patient.
Right. So the most common would be, faulty techniques in these things, difficult to treat. Your asthma plus where they're having comorbids, usually they tend to, go along together. But you can have alternate diagnosis as we have seen, and we'll show you a few more. But it can be a true therapy resistant asthma as well. Right. Now, when we went ahead and did x-rays for this child and reviewed these x-rays, you find some opacities here in the right middle lobe area, some saluting which is seen. Again, in all these x-rays, some areas were appearing to be not consistent with the diagnosis of asthma, right? And the CT was showing opacification of the sinuses. I do understand this is not the best investigation for picking up a sinusitis. So we did a lung function. So just one comment on the lung function, Dr. Mrityunjay.
In this patient, we can see that the This patient simply does not show any pre and post bronchodilator change improvement. So this is a patient who is has obstructive disease, who is not improving to.
Yes. So there is a definite obstruction which you can appreciate in the graphs. You can also see that there is no significant change after giving a bronchodilator.
It's a mixed pattern basically.
Yeah, it is a mixed
also
pattern.
The FVC is very poor, 43%. So either there is air trapping or there may be some restrictive component along with it.
Absolutely. So it is a mixed disorder, but there is significant obstruction and there is no reversibility. So that is what we are trying to interpret.
So like 65 doses, all those conditions, PIBO, so they may have...
Absolutely. Absolutely. So we are thinking in terms of mimickers here, right? And these are the usual mimickers which you would see. So you'll have suppurative lung disease, bronchiectasis, bronchiolitis obliterans, and ABPA. These are a common group of mimickers. Then you can also have congenital problems which have been missed previously, like malacia, but you can also have CF, PCD, and airway compression. So look at these differentials as well. So this child was evaluated further. A CT was done. It shows areas of bronchiectasis. So these are dilated areas which you would appreciate. They are areas of atelectasis as well. You can see all along these areas. So this child actually has an atelectobronchiectasis. We evaluated for CF, which was normal, immunoglobulin profile was normal, HIV was negative, ABPA workup was normal. Bronchoscopy shows significant mucopurulent secretion. The BAL was absolutely normal. So this child was started on chest physiotherapy, azithromycin, alternate days, early treatment of exacerbations and the regular vaccines. Remained stable. In the X-ray also shows some amount of clearing. So one of the common differential diagnoses or mimickers of asthma could be a suppurative lung disease, which is actually being missed. So in these situations, be careful. So this 11 years old presented with breathlessness and cough for a year, right? With occasional wheezing and otherwise looking well. And so, Dr. Rashmi, this is the lung function of this child. So can you just comment on the lung function of this child?
So it is very kind of looking like a kind of, the volume is very less. And if you can show the spirometry, so we have to basically see what is the FEV1 by FVC ratio. So if it is normal or increased with a very low FVC, so we can think of it may be a restrictive disease.
Yeah, so actually this curve shows restriction. Somehow that graph has disappeared from here. But these values were quite low. The FEV1 and the FVC ratios were normal, but the FEV1 and FVCs both were in the range of 30%. So this was actually not a child who was possibly having an asthma, and it was a child who was possibly having a restrictive lung disease. So these would be interstitial, neuromuscular, thoracic, extrathoracic, or pleural. We'll not go into much of detail because I'm just running out of time. These were X-rays, and sometimes if you have digital X-rays, they can be confusing, whether they are normal or there is some areas of ground glassing.
Reticulonodular opacities are there also.
On further evaluation, this child was having significant amount of ground glass opacity, which was there, some amount of pneumomediastinum, which was there, and there was significantly high pigeon protein droppings, which were there. So pigeon protein was significantly high. Rest of the hypersensitivity pneumonitis panel was negative, and we also did a transbronchial lung biopsy, which was consistent with a diagnosis of a hypersensitivity pneumonitis. So again, a child presenting with cough, a child presenting with wheeze and breathlessness, clinically being managed as asthma for the past 1 year or so. A lung function which helps you to understand, well, you're not dealing with asthma, you're dealing with an asthma mimic. Right, so I think I'll just skip this case on exercise-induced breathlessness and go on to, because I have 7 minutes left. So, Dr. Rashmi, you have 3 clinical scenarios here. You have 5 years old with suspected asthma, a very common clinical situation. You're not being able to perform a spirometry. You have a 3 years old with chronic cough, no wheeze. You're still not sure what this child is going around. And the third scenario is you have a 6 years old child who has a suspected asthma but has a normal spirometry. So what's the way forward?
So exactly we have discussed multiple times. When spirometry, it requires a lot of effort actually. Sometimes big children, they cannot do, and obviously small children, they cannot do. Okay, and in some cases also you are strongly suspecting asthma, but spirometry is normal. So in those cases, you can do either impulse oscillometry or the force oscillation technique. So these two you can do. And if they are abnormal, suppose spirometry is normal, but these are abnormal, and they are showing obstructive pattern, you can stamp that the child may have asthma. So these are now the gold standard, and they may replace spirometry in future also, both in children as well as in adults.
So the advantage of impulse oscillometry is that it assesses the resistance directly, one, so it is more sensitive, and if you see a good reversibility there, you can tell it is reversible. And the second is the small airway disease which are not picked up by the spirometry, you can pick them up, and as told in different literature, about 30% of children and in 50% of adults, the asthma is small airway disease. And the medication for small airway disease also, now we know the small particle steroids are coming up, so it may be different. So it is very important that we learn this tool and use this tool more frequently than what we do right now.
So if even tells you the large airways, it doesn't tell about the small airways. So in that way, IVS will score high over the spirometry. It can detect any problem in the small airways.
So this is what it looks like. There's a loudspeaker which produces sound waves of multiple frequency. These sound waves passes through here, and the child is breathing with the pneumotac in between. These sound waves get superimposed on the breathing of this child, and when these sound waves are reflected along with the breathing of this child, right, the pneumotac is going to catch these sound waves. What happens, what is the change which happens, and that is what gives you a resistance and reactance. So you get X values, which is your resistance, you get R values, which is your reactance, and you will get it across, R is the resistance and the X is the reactance. The R values goes along, as you can see, from 5 hertz to 30 hertz or sometimes 40 hertz. And similar for
so just in spirometry, we get flow volume and the volume time loops. In impulse oscillometry, we get the resistance and the reactance. So looking at this loop, and what is the basic principle? The R5, it is transmitted longer distance. So all of the airways can be picked up. R20, only shorter distance. Say, division till the 7th division. And the minus R5 minus R20 gives us the small airway. That's the basic principle.
Right, so these curves could look like this in peripheral airway obstruction, where the frequencies at smaller waves are actually affected, and they're not as affected as at larger waves. In central airway obstruction, they might be affected simultaneously. Okay, so Dr. Indran will help us to look at these reports. We have around 3 minutes left. So this is the first child, 5 years old with asthma, a failed spirometry, and iOS.
So yes, see, as I told that impulse oscillometry is a more sensitive, and you can do impulse oscillometry even in a 1 year or 2-year-old child. So what you see is that the resistance and the reactance, the resistance is the up one. So I have to have the point, you can just point at the pointer, the resistance at 5 hertz and resistance at 20 hertz, you see? And you can see the absolute value. Resistance 5 hertz is predicted is 0.87, and he is having 1.41. That is 162% of what is predicted. So anything above 150% predicted means obstruction. And you see the reversibility of 13%. Ideally, the reversibility of 20% shows good bronchodilator reversibility. But what is important, the R5 minus R20 is also raised. So this is small airway obstruction with some sort of reversibility. So now we can tell that small airway obstruction with reversibility is there. So we can stamp this patient as obstructive airway disease, and a 5-year child having obstructive airway disease with some sort of reversibility is asthma.
Okay. So
And the area under the curve is also AX is very sensitive tool. So you go back to the previous slide. So AX, this area. So with bronchodilator reversibility, if the area under the curve changes, it's a very sensitive tool to tell us that the child is having good reversibility. And the FRES. So FRES, which was initially say 15 seconds or 10 seconds, and it decreases to 6 seconds, it's also a very good predictor. And if the FRES decreases, that means the area under the curve will also decrease. So these are all very, very sensitive tool to pick up reversibility and to pick up obstruction.
right. So around 1.5 minutes left. So this is the other child who has chronic cough with no wheeze, and again you can see that the R5 values are raised, and here you can also see that there is a significant
Reversibility is very good
which
in this
seen.
child. So this is cough, though we are leveling it as cough variant asthma, basically this is asthma.
Yes. So
But
3
again,
years,
how confident are you in telling a 3-year child to be asthma, where we are
No.
not leveling asthma
No.
because
So
these
we
are
are-
multi-trigger wheeze?
yes. So we are not trying to say that this child has asthma or no asthma. What we are trying to say is that this chronic cough appears to be because of an obstructive airway disease. This child needs to be on inhaled corticosteroids, right, for symptomatic treatment for a period of around 3 months. And the diagnosis of asthma has to be made in follow-up if you feel that this child persists to have symptoms, right? So what we are trying to say is that it helps you in this clinical situation to understand what's going on. We are not trying to say that you're labeling a child as asthma with this obstruction.
So we tell that, okay, that recurrent wheeze we classify as per the probability, but high probability they have to be managed like asthma. So you can tell parents that he will receive the treatment of asthma, though we are not labeling, but it is like something like
Yes.
that.
So
Strong family history is there. Strong family history is there, and the response to steroid is very good. Probably these are going to be asthma, and what is important is that they should continue with the inhaled medication for a longer period of time, knowing fully well that if they are stopping it, airway remodeling and exacerbation will be more frequent.
okay, so this child was not wheezing. So I'll just take one minute more and finish it. So this is the third child where the spirometry was normal, but clinically looking like asthma. And again, the iOS shows obstruction and it shows.
It's very good reversibility. Yes, please.
So regarding what Dr. Ankit you have shown, so R5 something more than 140 that indicates increased resistance. So this AX area under curve more than 40%. So either a change in 40% for area under curve and change in 20% after the bronchodilator, we can tell that there is a very good reversibility.
6 years. So with the 6 years child, you see the obstruction, small airway, again a good reversibility minus 42. So yes, this is asthma. This can be stamped as asthma.
Okay, so we'll just end here. We still understand that the most useful lung function remains as a spirometry, right? There is absolutely no doubt about it. This message should be clear to everyone that that is the most robust lung function that we have. There are other tests which are useful like oscillometry, but you need to have a spirometry associated with that. Otherwise, you will see a lot of patients where spirometry is abnormal and iOS can be normal, but you can have, as we have shown, a few patients where The spirometry looks okay, but the IOS shows obstruction. So spirometry is something which should be available with most people who are treating.
Ankit, FINO is also a very good tool. Again, it tells us about the airway inflammation. The previous child, if the FINO was higher, 35 or something more than that, I would be more confident in giving inhaled steroids and telling that this child is having airway inflammation and it's an eosinophilic inflammation.
Right. And sorry?
Absolutely, sir.
See, I think we had put up a case there, but we could not deal with that. So if you have a child who presents to you with exercise-induced symptoms, what are you going to do? Now, there are established protocols regarding this, and what you do is an exercise challenge spirometry. So the child is made to exercise on a treadmill on a specific protocol. There has to be a target heart rate which has to be achieved for a period of 8 to 10 minutes, right? And when that is achieved, you are looking at symptoms, whether this child actually develops that breathlessness or that stridor or that noisy breathing or not. So that's one. What you are in addition looking at is a fall in the FEV1 post treadmill exercise challenge. So fall in FEV1s by more than 10 or 12% is something which is diagnostic. You also need to remember that most children who present with exercise-induced breathlessness don't have asthma. Okay, they don't have asthma. Only 10 to 15% will have asthma. Rest could be that, you know, they are deconditioned, which means that they are not exercising and hence they are not able to tolerate their symptoms. There's a specific entity which is known as exercise-induced laryngeal obstruction. Now, how do you pick up that? So, presence of stridor during this test is something which will help you. But the diagnostic modality which is used world over, which we have not been using and I have no experience on that, is doing a continuous laryngoscopy while during that exercise. Right? So, that is something which is done at across international centers, and that is something which is diagnostic for this condition. So, we need to end it here. Thanks for the lovely discussion to all my panelists, and thanks to delegates for being here. So thank you very much. Thanks to the organizing committee for inviting us here. Thank you.